Hi, I'm Michael Cheezum, the chair of the FiRST committee, and I'm at Brigham and Women's Hospital. I'm here with Dr. Todd Villines, who's the Army consultant to the Surgeon General and director of cardiac CT and the Cardiology Fellowship at Walter Reed National Military Medical Center. Dr. Villines, thanks for joining us today.
Hey, thanks for having me, Mike.
Dr. Villines, there's a lot of discussion and almost really controversy about the most recent guidelines from 2013 ACC/AHA regarding prevention, and particularly with the use or lack thereof of imaging to guide prevention. What do you like about the guidelines, and what do you not like?
Well, I think just to start off, what do we like? I like the fact that we have aligned the doses of statins used in clinical outcomes trials with our guidelines. I like the fact that I think in general it expands the number of Americans eligible for statins, which I think is ultimately a good thing. And most of us in the prevention world would agree that there's probably an under-treatment effect prior to these guidelines. I like the fact that it expands the definition of cardiovascular disease from just hard coronary events to include things that I think are very clinically important and relevant, to include things like stroke. And I like the fact that it tries to incorporate, I think, some differences in gender and other ethnicities into its risk calculator. And so I think there's a lot to like in that respect. I think the issues that I have with the new guidelines are, as you mentioned, that it still puts full faith in probabilistic risk equations. So it's really just kind of a dressing up of Framingham, and we all know the significant limitations of using risk factors. And I think most of us in imaging have come to the conclusion, particularly when you look at the coronary calcium data, that we have better ways of assessing risk in most patients. We have, for example, coronary calcium. It's one of the most consistent findings in medicine that it trumps risk factors time and time again. It trumps biomarkers like highly sensitive CRP. There's really nothing that better assesses one's risk than documenting clinical atherosclerosis. It can be done cheap and easy. It's reproducible. It's non-invasive. And I think my hope was that we would move towards more personalized medicine instead of putting our full faith in these probabilistic risk equations and just trying to find a better equation. And so I think a lot of the controversy was the fact that the equation that was published wasn't prospectively validated. It kind of hit us all at once. We didn't get a chance to look at it and see how it performed in populations, and so that was a lot of the controversy as well. And I think there's some validity to that, but I think one of my biggest concerns is that I think regardless of how well we've dressed up the risk factor equation, I think we know from very good data with atherosclerosis imaging that there are much better ways to assess risk, and our hope is that we would move towards that.
So whether it's calcium scoring or other modalities, it sounds like we know that to look at the problem, it's best to just look for the problem and individualize risk. So calcium score certainly has a role for that. What about lower is better? How do you feel on that front?
Well, I think I would agree. I think calcium scoring is by far and away the most validated measure of subclinical atherosclerosis and coronary disease. I think the throwing out of the targets, if you will, I understand the rationale. The targets were not prospectively validated, but I think there are some potential concerns with that. I think number one is just a practical matter of our patients liked having that goal in many cases. On the other hand, it does make your life a little easier, not having to constantly, add other therapies and check numbers. So I think there are some pros and cons of that. I think we need to be careful about completely discrediting the fact that lower is better. And I think many patients will still have LDL cholesterols over 100 despite current guideline recommended statins. And I will tell you that given the evidence from LDL reduction trials, those patients still make me very nervous, and I will probably still escalate therapy using statins in those patients.
Dr. Villines, thanks for your time. We're joined here at SCCT 2014 in San Diego. We'll be in Las Vegas next year. We hope to see you there. For this and more interviews, please join us at youtube.com/firstinimaging. Thanks, Dr. Villines.